Now we'll move to the next topic. It's my pleasure to introduce the next speaker is Dr. Mohammed Almajed. He's a consultant anesthesist from King Khalid University Hospital. In the next 20 minutes, he's going to address the topic of spinal cord stimulation for chronic pancreatitis. Welcome, Dr. Mohammed.
Assalamu alaikum. Good afternoon, everyone. First of all, I'd like to thank Dr. Majid Al-Madi for inviting me to speak about spinal cord stimulation today. Yes. Okay. Before I start the presentation, how many of you referred patients with chronic pancreatitis to pain clinics and had spinal cord stimulation?
Dr. Mohammed, just can you close to the microphone, please?
How many of you referred patients to pain clinics because of chronic pancreatitis? Did anyone get spinal cord stimulation? No. Okay, we'll start with the introduction, then talk about spinal cord stimulation, and then some published literature on the subject, and then we'll end up with the case report. The classification of different pain conditions is quite massive. We can classify pain based on temporal basis, pathophysiologic basis, and each specialty deals with pain in a different way than other specialties, for example, deal with the pain. Pain seems to be a symptom. It is taken as a symptom in most specialties, but in our specialty we take it as a system which could have dysfunctions. The most important thing here is the visceral pain. When we talk about visceral pain, we should differentiate between visceral nociceptive pain compared to visceral neuropathic pain. The first one seems to be dominant in acute conditions, while the other one is dominant in chronic conditions, such as chronic pancreatitis and other abdominal pains. The anatomy and the physiology of visceral pain is quite complex, but there is an huge autonomic association with it, which is susceptible to sympathectomy that is caused, for example, by spinal cord stimulation. I'll skip this one. For those of you who are interested in the management of pain in chronic pancreatitis, there is a very nice review in the Pain Practice Journal, but it is a bit outdated since it's published in 2011. Before we talk about spinal cord stimulation, this key publication was published in Science in 1965, which described the relationship between the non-noxious stimuli processing in the spinal cord compared to the noxious stimuli processing. The first one is conducted through A beta fibers, while the second one is conducted through A delta and C fibers. And they noted that whenever you stimulate A beta fibers, you reduce the traffic or the firing in A delta and C fibers, meaning that if you stimulate touch, for example, you close the gate on the stimuli coming from the primary afferents carrying noxious stimuli. And a good example of that is whenever you hit something and you get pain, for example, you hit your hand on a sharp object, you immediately grab it and try to touch it, and this clearly shows the effect of stimulating A beta fibers on the C fiber traffic. Spinal cord stimulation is started in the 1970s which is 5 years after the publication of that article. Basically, it is very similar to what women get in labor. Instead of putting a catheter in the epidural space, we put an electrical wire in the epidural space, and this wire, instead of getting drugged, we start an electrical field that eventually passes through the dorsal column, where all these primary afferents go in. And as you can see in the spinal canal, the tip of the lead is right behind the coda equina, or the spinal cord, if you go higher. And that will alter the processing, how the primary afferent neurons communicate with the second order interneurons. And typically the patient would be awake in the operating room. They would be given a little sedation. It is a very minimally invasive intervention, so the patient would feel when you reach the segment that you target. For example, we target T8 or T5 in the spinal cord to get stimulation of the viscerotome, the pancreatic area or the subcostal area. They would feel tingling and paresthesia. And when we get that, we fix the lead and we allow them 7 days, 5 days of trial, and then they would judge whether their pain is improved, their behavior, their quality of life, consumption of medication, and then we decide whether they go for implants or not. So this is how it looks like. The electrical lead is right behind the spinal cord, and sometimes there are other technical ways, different technical ways of doing it. For example, there is the ventral root stimulation, which is different from the dorsal column stimulation. This is how it looks like a pacemaker. The generator is connected to the electrical wire, and the electrical wire goes into the epidural space. And it's a totally closed system, and the patient would be given a remote control to turn it on or off, and will be able to increase the voltage and reduce it, because sometimes they lose the effect as their position changes. It's different when they're lying or when they're standing. This is one of the biggest, unfortunately it's a small case series, but it's really important, published by Caporal. Looked at 30 patients labeled with chronic pancreatitis and with, of course, with chronic abdominal pain. Underwent trial for 7 to 14 days. The spinal cord lead tip was positioned at T5 in 10 of them, and T6 in another 10. And then 24 patients. We will look at that through the next slides. This is how it looks like on X-ray. The tip of the lead is at T5. They define success as more than 50% reduction in the visual analog scores, or the numerical rating scales. 24 were successful, more than 50% reduction. The unsuccessful ones didn't show that much pain reduction, although they got good stimulation. They got very good stimulation, but they did not benefit from that stimulation. They also looked at the long-term improvement. It was sustained compared to baseline and was statistically significant. They also looked at the consumption of morphine sulfate equivalents, because they were on different kinds of opioids. And that was also significant compared to baseline at 1 year after the implantation. These are some of the published papers on different abdominal conditions. As you can see, irritable bowel syndrome, mesenteric ischemia, chronic esophageal dysmotility, post-traumatic splenectomy, familial Mediterranean fever, gastroparesis, chronic pancreatitis, and post-surgical intra-abdominal adhesions. This is another report from Vergani and his colleagues. They looked at two patients, 50 years old and a 39-year-old. The difference here is that the tip of the lead was quite lower than the one reported in the Caporal paper. And they followed up the patient for 7 years and showed remarkable improvement and reduction in pain scores, 80 to 90%, and also an effect on opiate consumption. This is a report about first case done in New Zealand. It shows that the background pain severity of 3 out of 10 was nil after the spinal cord stimulation, and the attacks disappeared completely. And also they showed some reduction in the morphine sulfate equivalent analgesia. That's another case report by Kim and his colleagues. And this leads to our case report here. Now, this case was presented to the emergency department with abdominal pain, treated conservatively, and was then referred to outpatient clinics. And she had an ultrasound that showed gallstones, and she was planned for cholecystectomy, which she had with no complications. Then later on, she presented with a picture of obstructive jaundice, and ERCP was done, and it showed some CBD stone. And I think they did a CBD pancreatic stenting as a prophylaxis. Post ERCP, she developed severe abdominal pain, and they were thinking about pancreatitis and perforation, and the CT and MRI were done. They were suggesting perforation. She had laparoscopic exploration, which showed, I think, acidic fluid with bile. That led to laparotomy with no evidence of perforation. But they left some drains, and the patient later was discharged, and later CT showed a reduction in the size of the collection. And then she went into, she was labeled as chronic pancreatitis because she was frequenting the clinic, and no abnormalities were found later on. When she was seen in February 2015, and by the way, she failed drug therapy, which included NSAIDs, paracetamol, Tylenol 3, pregabalin, and wanted to go ahead with spinal cord stimulation. She had a 1 week of a trial, after which she reported no more attacks and no background abdominal pain. She was implanted the week after.
Mohammed, you have 4 minutes.
And discontinued all analgesics. And by the way, when she was seen, she stopped work because of the multiple medical problems she was having. And this is how the lead looks like. If you can see on the AP image, the tip of the lead is around T5 or D5 vertebra. And on the lateral view, you can see the lead as well sitting in the posterior part of the spinal canal. A couple of times we had to change the program because she was feeling the stimulation going to the heart. And then we would change the program to allow the stimulation to go on the lower part of the in the upper part of the abdomen, the subcostal area. After the last program change, she continued to report zero pain, and she's thinking about returning to work. We can take questions if you want.
Yeah, you finished? You have 2 minutes more. Okay, leave maybe the discussion later. You finished?
I can talk about if they have, because the talk is big. It's about spinal cord stimulation, and I don't know how much they want to know and in what area they want to know and ask.
No,
I can answer questions.
We can leave the question at the end with all the speakers.
Okay.
You finish.
Thank you.
So,